much. Elementary school was the worst.
Growing up with a congenital heart defect, Kaitlyn Dubaz had a lifetime of specialized care that continues into her adulthood. We shared the changes requiring this latest unique procedure so she can live her best life. That's today on All Things Heart. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Kaitlyn Dubaz is very familiar with heart procedures and surgeries. She's undergone several of them since she was born. And for her latest procedure here at the health system, she and two of her doctors invited us into the procedure room to watch.
I know in elementary school, there were times where PE class would be happening and I would have to sit in the bleachers and not participate.
26-year-old Kaitlyn Dubaz has been a heart patient since the day she was born, with her pulmonary artery and aorta connected to the wrong parts of her heart and a hole between the bottom two chambers of her heart.
But after I was born, they noticed something was wrong and I got airlifted by helicopter to Children's Mercy. I got 2 open heart surgeries done.
One of those surgeries was a Fontan surgery to improve blood flow by disconnecting her inferior vena cava from her heart and reconnecting it to her pulmonary artery, using a tube to make a new pathway. But over the years, that new pathway has narrowed.
I fatigue quicker. I can't maybe lift as heavy as some people. I can't keep up with other people my age.
Her cardiology team is putting in a stent to widen the Fontan pathway created when she was just a little girl.
It expands the diameter of the Fontan to allow more blood flow.
At the helm, University of Kansas Health System cardiologist and Adult Congenital Heart Disease Program Director, Dr. J.D. Surface, and Children's Mercy Hospital cardiologist, Dr. Toby Rockefeller, who also specializes in congenital heart defects. These two often team up when treating patients who've transitioned to adult care from their pediatric care team.
Just oxygen.
Because the anatomy of someone born with a congenital heart defect can be so different compared to the heart patients without anomalies,
this is what they're talking about. So
before the procedure, Dr. Surface uses a dry erase board and markers to explain to the rest of the team exactly what's about to happen. It's just one example of the many qualities Kaitlyn says she appreciates most about him.
I like talking to Dr. Surface. He's really straightforward and he's very nice. He likes to educate.
They reach Kaitlyn's heart by going through a vein in her leg, operating most of their tools while watching the screen above the procedure table for guidance. And take a look at that mesh tube at the center. What you see there is one stent already deployed, and that tube is a second stent not yet deployed. Kaitlyn's procedure requires 2 to cover the length of the passageway, or Fontan conduit. Once both are in place, the doctors will dilate them with balloons until they open up the passageway to the target size. And Kaitlyn will be home by tomorrow with greatly improved energy levels, just in time because she has a big trip planned with her husband coming up.
Kind of as like a 1-year anniversary/honeymoon type deal. I do want to tell other people with my condition that you're stronger than you think. I just want other people with my condition to feel just as strong as I do sometimes.
We are so happy to have Kaitlyn's cardiologist and the director of the Adult Congenital Heart Defect Clinic here with us, Dr. J.D. Surface. Thank you for being here.
Thank you.
And we also have the amazing cardiologist, Dr. Toby Rockefeller. Dr. Rockefeller works here at the health system with patients like Kaitlyn. He's also, as we said, the congenital heart defect specialist at Children's Mercy Hospital. Thank you for joining us.
Thanks for having me.
And of course, we have Kaitlyn joining us virtually this morning. Kaitlyn, good morning.
Good morning.
First of all, tell us about the kitty cat next to you.
Oh my gosh. Okay. So back here. Oh, now that we're talking about kitty cats,
another one.
my
There's
kitten
2.
is also in. Yeah. There's my kitten. His name is Crunchwrap. The foster family named him that, and we've kept it. And then behind me by the window, that's my older cat, Cleo. Yeah, this orange guy, he's 6 months old.
Oh, wow. I love it. That'll add a lot to this discussion. Kaitlyn, how are you feeling today?
Oh, I'm feeling great. Like, today's been a good day so far.
Did you get to take that anniversary trip with your husband?
Oh, yeah, we did. Like, honestly, when I went, I just did a lot of like resting. That was a very restful trip. I thought we would go on hikes and stuff, but really, like, the cabin was so nice and it rained on a metal roof, and it was
amazing.
wonderful.
Where
Yeah.
were you, Kaitlyn?
We were in Tennessee, kind of near the Smoky Mountains. I think the city was called Pigeon Forge.
Yeah, I know Pigeon Forge. Yeah.
Heard of that?
Yeah.
Boy, those are the best kind of
awesome.
vacations.
Yeah.
You always have big plans to do things.
All right.
And then that coffee tastes pretty good.
It
Kaitlyn,
was restful.
how old were you when you had your first surgery?
My first surgery. If I'm correct, it's 2 months old.
Okay.
So, like, super duper young.
Oh, man. And so, Dr. Surface, that pathway was originally fixed. It narrowed over time. Why does it narrow over time?
You know, it's a great question. I think in Kaitlyn's case, it's a combination of two factors. One is, yes, it narrowed some over time, but probably more important than that is that when it was implanted, Kaitlyn was just a few years old. And so it was the right size for her when she was 3, but not the right size for her as an adult.
Oh, okay.
But even so, they do shrink some over time. And so Kaitlyn's, if I'm recalling correctly, was implanted at 16 millimeters in diameter. But when we measured it, you know, it was closer to 11 or 12.
And so that was when she was a toddler, she had this?
That's right, yeah.
But the first surgery was 2 months. It's so fragile.
Yeah, it's pretty impressive. And
age.
Dr. Rockefeller lives that world at Children's Mercy more so than I do with neonates and young children getting surgeries. But they get them through it, and it's a real miracle.
Yeah, I was looking back at Kaitlyn's chart. It's like, because everyone has a very unique pathway to the
Yeah.
Fontan surgery. If you look at the Fontan procedure itself, you know, it was first done in like the late 1960s, and it has evolved ever since. And the Fontan procedure is really reserved for patients that don't have 2 good pumping chambers. So they don't have the part of the heart that can pump blood to the lungs.
Okay.
And when Kaitlyn was a baby, the hope was that we would make her a 2-ventricle repair. But when the surgery, they went in there to do that, they realized they couldn't because of the way her heart was formed. They really had to leave her with just a single pumping chamber, which is why she went down this pathway towards the Fontan. So it's a series of surgeries that make this type of anatomy survivable.
You said we, but you don't look old enough to have been operating on
No.
Kaitlyn when she was a baby. So this was another team
Yes.
at Children's Mercy. Okay.
And if you look back at the history of congenital heart disease and the heart surgeries, I think it's inspiring. It's amazing what they were willing to try and able to do, and the progress they've made in the last, 60 years. And all this evolution has happened for Fontan patients specifically since the late 1960s.
It's
And
incredible.
you see the way that her heart was fixed with this Fontan procedure. The way hers was done was with this tube, this Gore-Tex tube that measured 16 millimeters in diameter when she was 2 years old.
Right.
The way of doing it that way was only first described in the 1990s.
So is it common then for you to now both see patients who had this done a long time ago and now you're, whoa, we've got to update this? Is that common?
You know, it has become common.
Yeah.
And to some degree, it's, this is just one more evolution in, as Dr. Rockefeller said, this has evolved a lot over the decades. And, Kaitlyn, when you had your Fontan placed, I think the thought process was get the Fontan done early and put in, a conduit that's sized for a small child. Nowadays, if you were to start over and be born today and need a Fontan surgery, I think they'd probably wait another year or two and put in a much larger conduit. And so,
Yep.
But Toby and I now follow a large cohort of patients who have all been treated with 14 and 16 millimeter conduits, which we have realized is too small. But thankfully, we've also realized that we can make them bigger safely and effectively and make them more appropriately sized for an adult.
And there's I was going to say, Kaitlyn's narrowing in that Fontan pathway is actually something we see pretty universally.
Okay.
You know, you get the conduit put in when you're a toddler, and 20 years later, it's always going to be smaller than its original diameter.
Kaitlyn, what were the symptoms that you started having, and when did you start having them as that pathway narrowed?
Well, the interesting thing about that is that, when you're born with a heart defect, you don't see your symptoms as symptoms. You just see them as that's how you are. So, I was kind of blown away when I got to the doctor's appointment and they were like, we need to expand your Fontan and it'll improve your life. I was like, I'm sorry, how? Because
you had nothing to compare it to?
Adapt. No, you've got nothing to compare it to. And I would just, for example, an improvement I've noticed is that I don't burn as much in my legs with that lactic acid production. And so it's one of those things where it's like, oh, that was a symptom, but I just thought I was out of shape, or I just thought that's how running or exercise is supposed to be. Right. You've got nothing to compare it to. So, that I know is the most, and just overall, my stamina is low. But again, I thought it was just, oh, that's just how I am.
That makes total sense. So this wasn't something that you went in saying, doctor, I have these symptoms. This was something that kind of surprised you during a checkup?
Absolutely. Yeah, I didn't know it was an issue to begin with, or at least just a thing. I know I had a Fontan, but only during that appointment did they educate me like they did just now about how, the narrowing, what its intention was at the time and what needs to happen.
That's super interesting, and that makes total sense. So I want to go back to all the incredible changes that have been made and the advancements. What would this treatment then that you did, that Dr. Rockefeller and Dr. Surface did when we first met Kaitlyn in the procedure room, what would that have looked like 30 years ago? Did it exist?
Well, so, stents existed.
Yeah.
So the technology to do something like this existed, but, 30 years ago, the patients with Fontans who were walking around at that time probably didn't have the same problem, because 30 years ago was when we first started putting in these tubes in this way. But certainly, creative congenital interventionalists like Dr. Rockefeller and my mentors have certainly used stents and balloons and devices in a lot of creative ways to help patients with Fontan in a lot of different ways. Sometimes it's a pulmonary artery that needs to be stented, or a collateral vessel that needs to be closed. So there's a variety of different ways that we've been able to help patients in the cath lab. But particularly what we did is something that's really only become widespread in recent years, as many of these patients who were first treated with these small conduits have grown up, and we've recognized that that's not sufficient for an adult.
Right.
Yeah, I would say 30 years ago, if you had a problem with that Fontan pathway, you were going to have surgery.
Uh-huh.
And I think we have learned that having surgery in the Fontan pathway as an adult would be a highly morbid procedure.
Right.
A lot of things can go as you didn't plan. And so then we tried to avoid surgeries as much as possible. And then the evolution to this kind of Fontan happened because we wanted to avoid doing more surgery on the heart itself and not sacrificing parts of the heart to form that pathway. So we just put the Gore-Tex tube in there now and just kind of leave the heart alone, just put that tube around the outside. But now we're realizing that it gets narrowed. And like he said, over the last few years, we've been able to stent these and make them bigger. But before that, we didn't even know that we could do that.
Right.
So it's a few brave people trying it and making it bigger, and then they spread the word. And then we just, follow their lead, and everyone is now kind of routinely doing this procedure to make life better for adult Fontan patients.
And now we have Kaitlyn, who's into her adulthood, living great. She went to the Smoky Mountains, had a great vacation. She's got her cats. So if someone, the problem Kaitlyn was born with, let's just say a baby had been born with that 30 years before Kaitlyn was born. What would pediatric heart doctors do to treat that? Was there a treatment for heart problems like that if like 30, 40 years before Kaitlyn was born?
Yeah, it is interesting what they would do for patients. You know, you go back 70, 80 years, there was nothing you could do.
Gosh.
And for many patients, you know, they wouldn't survive the first few weeks of life, let alone the first year of life. And in the 1940s, they started to do a shunt that would take blood to the lungs for babies that didn't have good blood flow to the lungs. And so Kaitlyn's, her anatomy was kind of perfectly balanced, and we saw that, you know, even 70, 80 years ago, you would see babies that had hearts that weren't normal, but they were perfectly balanced. They had the perfect amount of restriction to blood flow to the lungs, but there was enough there that they survived, but that was by far the minority of patients. And now, if babies are born with limitations in blood flow to the lung, we can supplement that with these little tubes called shunts. And the majority of patients now with these types of problems are making it into adulthood.
That's great.
When that, you know, 50 plus years ago was certainly the minority of patients making it to adulthood.
We have this really great video because Dr. Rockefeller and Dr. Surface invited us into the procedure room, and thank you for letting. Is it distracting to have a photographer there?
No.
No.
You just did your thing.
Yeah, just you know, they did a great job at, you know, letting us do our thing.
Great job.
Yeah.
It makes you feel like you just have a room full of interested students.
Yeah.
And you do. We're all learning from what you do. Kaitlyn, what's it like to see this video for the first time?
I feel like I'm learning just so much. It's kind of surreal because I feel like the only surgery you get to see is on TV, but this is like a real video, and I don't know, like it's very cool. That's the most I can say. It's super cool.
Before the procedure, we saw Dr. Surface. I loved this. You got out the whiteboard, and you're drawing on the whiteboard, describing things. Why is that so important for you to do in a case like this? And do you do that before every procedure?
So I'll take the second. I don't do it before every procedure. You know, so in the adult cath lab, if we're going to do something like we take a look at someone's heart arteries, that's something that we do in the adult cath lab, you know, 20, 30 times a day. You know, so everybody in the lab kind of understands how that goes. But in the congenital heart disease space, one, it's much less common. So we don't do these every day, especially not, you know, some of the cath lab staff who are not trained in congenital heart disease. But more than that, every single patient's heart with congenital heart disease is unique. Mm-hmm. They're all just a little bit different, the way things are hooked up, the types of surgeries they've had. And I find it's very useful before the case to have everybody in the room review the anatomy, review exactly what we're going to do and why we're doing it, and what are the complications we may be looking out for and how we'll manage them if they run into it, so that everyone's on the same page, so that we can move efficiently and effectively through the procedure as a team. So I find it very helpful.
What I also find interesting, and Dr. Rockefeller, I want to ask you this, we were looking at the screens that you're looking at as you and Dr. Surface are guiding things through Kaitlyn's body up to that pathway. Was there ever a time that you didn't have those screens?
So you always have to have the x-ray.
Yeah.
And that has also evolved. Just like everything in society or life, you know, things have gotten way better. And you sometimes look at the old angiograms
Right.
where it was like continuous x-rays, you know, being delivered to the patient, and you still have grainy pictures. Now we have x-ray imaging and these huge screens. You see how big they are and how close they are. Very high resolution imaging at very low frame rates to deliver as little radiation as possible. And without them, we couldn't do these procedures. Like, you wouldn't be able to see what you're doing.
Right. So there's no way in the olden days they could have done this, because you can't eyeball something like that.
No, it's all inside.
Yes, you've got to see it. We have some great questions and great comments coming in. If you have a question or a comment that you'd like us to read out loud on the program, you can send it to us right now on YouTube, Facebook, or the All Things Heart email. All those links on how you can connect with us in real time are there on your screen. Dr. Surface, when it comes to the stents, and we have video of those the two mesh tubes coming up, why did you need to use two?
That's a simple question of length. So the stents we were using, the longest stent comes in about a 5 centimeter length, and Kaitlyn's Fontan was probably about 7-8 centimeters. So we just had to use 2 overlapping stents to cover everything. Yep.
Kaitlyn, how long after the procedure were you feeling like yourself? You look great, by the way. I mean, the last we saw you, you were in your surgical cap, the little bonnet and everything, and they were putting you under. How quickly after the surgery were you back to living life?
Oh, I was ready to, like, they kept me overnight, but I was, like, ready to head on home, like, within, like, a couple hours after. Like,
wow.
they let you, like, walk the hallways down there, and I would take my husband with me, and we'd just, like, walk the perimeter when I was bored. Like, I know maybe there was, like, a little bit of some, like, tenderness in the thigh area where they went in, but, they kept asking me, they're like, do you feel any different? And I am barely up and moving, so I'm just like, I know, I'm okay.
Yeah.
Yeah.
What are some of the things that you do now that you realize you were struggling to do, that made you out of breath, or that made your legs tingle? What are some of the things you can do now that you couldn't do comfortably before the procedure?
Well, when I exercise, I'm like attempting to jog and run, and anytime I even attempted to, like, it would take maybe a minute or so before, like, it's like above my ankles or the lower part of my leg would start to, like, burn again with that lactic acid feeling. I know going up and down stairs, unless if I was, like, on top of my exercise, I'd be, like, a little, like, you could tell it took some effort, a little maybe winded, but yeah, like, those things kind of just went away. Like, at least I definitely, it either doesn't happen or I don't notice it. Like, I feel like a lot stronger. Like, my endurance levels are just way higher than what they used to be.
That's amazing. One of the neat things is watching how Dr. Rockefeller and Dr. Surface team up to help patients like Kaitlyn transition from child pediatric cardiac care into the adult congenital heart disease clinic. Before this dynamic duo here, what would happen when a patient would age out of their child care? How did they know where to go? I'll direct that to you first, Dr. Surface.
Sure. So the short answer is that's been a process and evolution for a long time. And there has been adult congenital heart disease care provided at KU for actually many years. There was a doctor here by the name of Kevin Mulhern who was before me for many.
Him.
Yes, they sure. Yep, and I follow many of his patients, really all of his prior patients. But the process for transition was much less formalized at that time than it is now. And I think, and Toby, you can speak to this perhaps better than I can, but it seems a little bit like they'd sort of graduate from pediatric care and they'd get a list of doctors they could contact if they wanted, and
it's just up to you,
and it's just,
right?
And to this day, I still see patients, even patients with complex single ventricle heart disease like Kaitlyn, who were followed as a child and then not followed up, and they come back in and they're 40 years old and sick, and so we really work hard to try and keep people in care so that we can identify problems like this small Fontan conduit before it becomes a big problem. But nowadays it's much more formalized, and we have a protocolized, regimented process to really try and make the transition process smooth and welcoming and easy for patients and their families.
We interviewed another patient of yours, Dr. Rockefeller, and it was so neat because you're on this video with Dr. Surface and you're working with these patients to get them transitioned. It truly is a partnership.
The transition clinic is something we do at Children's Mercy Hospital now to
There's
formalize.
There's a whole clinic for kids transitioning to adult.
Correct, and it's a telehealth clinic, so they can just stay in the comfort of their home or in their car, is where I think most people are doing their telehealth visits. And it's a direct handoff of their care from the pediatric side. So we have like the pediatric nurses and myself kind of summarize everything. Patients get to hear the summary, and then the KU team is there to receive them. So like you're directly handing the baton, And that way you know that these patients have heard the plan. They have an appointment at KU.
Right.
The family knows where to go. We actually offer to come with them, like escort them here and show them where to go, because you don't want anyone to feel like they've just been medically abandoned. Like they don't know where to go, who to call, or what to do. So this way, I think it really formalizes the process. We have very few patients now that are lost to follow-up.
Right. We have some great comments coming in. So I want to get to some of the comments and the questions from our viewers. The first one is a comment for you, Kaitlyn. It's from Marcia. She writes, I just love what Kaitlyn said about going on vacation and taking time to rest and relax. I like that too.
Yeah.
It's the best kind of vacation. We have another comment from someone. What an exciting evolution for those with this congenital disorder to be able to correct or revise the initial fix to improve the quality of life. Which goes what you're saying. Kaitlyn, you were very enthusiastic about so you're going to go on another relaxing vacation?
Oh yeah, I'm a huge fan. This is going to sound very, I think the word people my age use, sorry, I'm aging myself, bougie. It's very bougie, but people, I love to go on cruises, and just being next to the ocean is great. So my next trip I'm planning is in June, and I'm going on a Alaskan cruise.
Oh, nice.
Wow.
That's a bucket list thing there.
Yeah, that's a good one.
Also, if bougie is an old person's word, I'm doomed. I didn't know bougie was aging yourself.
I think I use that word.
I use that. I'm twice as old as you, Kaitlyn.
I thought it was what I meant to say is it's something that people my age use, and
okay.
I'm just not with the slang on that. I don't know. It's just okay.
I think it's still a totally appropriate word.
Thank you, Doctor.
It is universal.
We have a question from Jeremy. He wants to know, how unique is everyone's various blood flow and pressures and structures when you're doing this procedure? Does uniqueness make it more challenging? Is each procedure a little bit different?
Oh yeah. Yes, the uniqueness is what makes it challenging, and this is why Dr. Surface and I work together on these types of cases pretty routinely, is because if you're in there and you're dealing with a very unique heart, it's nice to have another set of eyes to just kind of bounce ideas off of and say, if we want to land the first stent here and the second one there, or these are the stents we'd use, you have someone else that is experienced in doing this to confirm or deny the plan. But some people's Fontans can be very long and have a very kind of arced pathway to the pulmonary arteries, much harder to stent. Some are surrounded by other vascular structures that if you expand the Fontan, you might compress their pulmonary artery, their pulmonary veins, or distort the heart itself, like the atrium. And so it's really important to understand all of their anatomy in 3 dimensions and understand how we are making that a little bit different. And sometimes you make one thing better while you made something else worse, and you certainly would like to avoid that.
So everyone's unique.
Everyone is unique. I do think that the majority of these angiograms look, pretty similar, but they all have their unique thing. And so reviewing all of the imaging before the cath is, I think, extremely important.
Yeah, couldn't agree more. And that's why we, when we do a cath, you can only see the structures that you inject contrast in.
Right.
So when we're blowing up the Fontan, we can't see what's around it. So we have to know ahead of time, using imaging and other things, what is around it, so we can anticipate what are the things that we're at risk of compressing in this particular case, and how might we assess for that during the case, and how might that limit how big we make the Fontan. So there's a lot of nuance and a lot of sort of detail that you have to pay attention to with each patient.
As we wrap up the discussion today, I want to go to Kaitlyn. What do you want our viewers to take away from this discussion?
I just think that, having a good relationship with your doctor is key, because I'm glad to talk to Dr. Surface, and I don't get to meet him very often, but Dr. Rockefeller has, worked on me many times. It's having a good relationship with your doctor and asking them questions and taking that time for you to educate yourself is, I feel really important, because I feel I've learned so much on this podcast already, to see all the intricacies and stuff like that. But just having a good relationship with them just keeps you informed. And, you know, if you happen to have a different doctor, then, you know, you can take that information with you.
Dr. Rockefeller?
I feel like I say the same thing all the time, but in the congenital world, I like to say to families all the time, with new babies that have these problems, they may look at all the literature or read, you know, Google things and get worried or get scared. And I always say, like, look at the past and how far we've come in 50 years. Who knows where we'll be in another 50 years? You know, really look at the congenital history and be inspired or be hopeful that things can certainly be a lot better than you think they will be in 20 or 30 years. And we meet patients and parents all the time in clinic that are like, this is not at all what we were expecting when she was born. And so I try to tell families and patients to maintain a positive outlook and maintain hope that the future can certainly look better than you think it will.
Dr. Surface?
You know, I think the main thing I'd like to say is thank you to Kaitlyn. So thank you for inviting us into the procedure room with you so that we could share this with everyone. And thank you for being here today.
What a great talk. And thank you so much to our viewers for joining the conversation. If you'd like to watch or share any one of our previous episodes, scan the QR code on your screen. It'll take you to links of all of our past episodes and patient stories like Kaitlyn's, who is amazing. What a delight. I just love talking to her. Coming up tomorrow, we are joined by Bree Morgan, a woman who has survived so much with such remarkable strength and grace, a premature birth, a vicious infection, multiple amputations to save her life, and now a kidney transplant. That's tomorrow at 8 a.m.